Hello, good evening, and welcome everybody to tonight's webinar on shingles, a shingles update. My name is Andrew Minton. I'm your moderator tonight. I work for the Immunisation Coalition, responsible for the education program and actually overall everything with regards to the Immunisation Coalition. I am the Immunisation Coalition CEO. So we have a bit of a tight timeline tonight. Our presenter will speak for up to 45 minutes, allowing us about 15 minutes for Q&As. Please put your questions into the Q&A. If you're a first-time person asking a question, please put the abbreviation FT, and I will look for that and try my best to raise that question for you. Feel free also to use the chat function. And I'll do my very best to try and finish on time at 7 o'clock to respect everybody's time. So firstly, I'd like to cite the welcome to country, and then I'll introduce our presenter tonight. So I'd like to acknowledge the traditional custodians of the various lands of which we work and welcome any Aboriginal and Torres Strait Islander peoples that may be on this webinar tonight. I'd like to pay my respects, and on behalf of the IC, to elders past, present and future, and really celebrate the diversity of First Nations people and their connections to the various lands, animals and waters of Australia. Just some housekeeping. Everyone will be on mute except the presenter and myself, but it will be recorded and this will be available in 1 week's time. If we're not able to get to all of the questions, a question and answer transcript will be available with some links in there on key information which our presenter will go through tonight. So now I'd like to introduce the guest speaker tonight. His name is Associate Professor John Litt. John's from Adelaide. He's a retired academic GP and health physician in the discipline of general practice at Flinders University, and was the Deputy Chairman and of the National Quality Committee of the RACGP for 18 years, as you can see. His major clinical and research interests are in prevention and its implementation. Professor Litt has over 130 peer-reviewed publications, including a number of books and book chapters. To his credit, he conducted the first of 2 surveys, the Australian National Influenza and Pneumococcal Survey in older adults in 1998, and the Australian Zoster Attitudes and Beliefs Survey in older adults and GPs in 2009. Extending on his work and with his team, during COVID, they developed the COVID risk calculator called Coracle. It was a combination of efforts between the University of Queensland, Flinders University, Sydney University and QUT. And they developed the COVID risk calculator, which assists in the patient's decision-making process for COVID-19 vaccination. And more recently, the team led by John developed the long COVID-19 calculator for people who are looking to assess long COVID risk if infected with symptomatic SARS-CoV-2. That tool is available on our website, and we'll also provide you a link to that in the week's time. So, and lastly, John has been a member of several national committees, consortia, and scientific advisory committees, including the NHMRC, ATAGI, Cancer Australia, and NCEARS. He's also one of the inaugural directors of the ISG, now known as Immunisation Coalition, and is an active member of the Immunisation Coalition Scientific Committee. So a big thank you, Professor Litt, for joining tonight and giving us your update on shingles. There's some new developments since last year, so we look forward to hearing from those. Without further delay, I'd like to hand over to you to take us through your presentation.
Oops, I'm just trying to share my screen here, Andrew. Here we go. I think we're right. Okay. Oops, today let's go slideshow. Right. Thank you, Andrew, and to the Immunisation Coalition for giving me an opportunity to give people an update for shingles. And for those of you who attended nearly 12 months ago, there are some changes, although I have put a few things in that will be a refresher. So this is largely a summary of what I'm going to cover. And just to remind people of who's at risk from zoster, I'm going to talk about the burden of morbidity. And there's been a couple of interesting developments that I think people may not be aware of, is that there does appear to be an increased risk of dementia in people that get zoster, and that risk is reduced by getting a zoster vaccine. And there's also a risk of stroke, and some of the data around that's become a little bit clearer. So I'll talk about that later. I'll talk about the complications. There'll be a bit more on ophthalmic zoster because I think that often gets neglected. We do tend to focus on post-hepatic neuralgia, which is abbreviated as PHN. And I'm going to focus on the recombinant zoster vaccine because people will be aware pretty well 12 months ago, the Commonwealth turned off the tap on the live attenuated vaccine Zostavax and have replaced it with the recombinant vaccine. And at the same time, the recombinant vaccine went on to the program, the National Immunisation Program, so it's provided free to people over the age of 65. And I'm going to go through the studies there fairly quickly because people will be familiar with that, but they may not be familiar with the 10-year follow-up data to show that it has continuing effectiveness. And the other thing that Commonwealth have done is there are two very important documents. The web link will appear in one of my slides, but they've largely updated the immunocompromised chapter in the handbook. And I think that's quite a big read. It's a separate presentation in its own right, but it's worth people who are regularly providing vaccines to have a look at that. And the other document they've done is they've now clarified amongst all of the various immunocompromised conditions and medications that lead to some degree of immunosuppression, which ones will be eligible for Shingrix. So you remember last year they stated amongst those over 65 and some very specific immunocompromised groups, they were going to provide further data, and they've now done that. So there's quite a detailed table there talking about a whole range of medications, things like TNF inhibitors, JAK inhibitors, people who had chemotherapy. So it's too detailed. It'll be a bit of a laundry list for me to go through, but the link will be there. And so if you've got a patient who's got an immunocompromising condition or is on a medication that could do that, then that would be a very good resource to clarify that. I'll just remind people about the coverage, and then I'll talk about it just briefly. What are the things that can make a difference? Because I think while we've done pretty well with the vaccine coverage, there is still a group of people that are, haven't got the vaccine, and it's really worthwhile to address the barriers and some of the misperceptions that people have. So zoster's increasing, and the reason for that is twofold. The population is getting older, and there's larger numbers, and so with more numbers, and with people at higher risk, you're going to see greater numbers of cases. The other thing is that now that we're actually vaccinating children, we're not getting a boosting effect, so that people of my age, if the kids had chicken pox and we were around them, you would actually get a boost from your immunity if you had previous varicella, which would reduce your risk of actually getting zoster. But that group has now been vaccinated, so that boosting potential in the community in programs which have a very effective childhood varicella vaccine program has contributed a bit to the increase in that risk. So here's to put some numbers to it. So if you get to the age of 85, 1 in 2 people are going to have zoster. And if you, for a 60-year-old where the risk has already started to increase, your risk from then on, if you haven't had it, it's going to be at 40%. So that's betting odds. If you were in the Melbourne Cup with those odds, you'd take the bet. Post-hepatic neuralgic, you can also see goes up, and it actually goes up in terms of the incidence more steeply than the incidence of zoster. And so an 85-year-old, 1 in 5 of those are going to get post-hepatic neuralgia. And just to remind people, post-hepatic neuralgia is continuous pain for 3 months or more following a bout of zoster, and I'll talk in a bit more detail about that shortly. So, we get over 120,000 cases of shingles per year. The vaccine has made a difference, but it's still an issue for people. That said, with the survey that that we and others have done, is that largely a lot of people think they're not, or they may get zoster, but it's not the majority. And so an important perception, it's not like the flu or pneumonia, whatever. People who've had varicella, and older people largely have, where 95% of people will actually show immunity if you actually test it. It's not a matter of catching it, you've got it. It's a matter of it gets unleashed for various reasons. And so this, if you could live in a sealer's hut on South Georgia and no one came to visit, and you had chickenpox as a child, you're still at risk from getting zoster. This is a busy slide, but it does summarize in a systematic review what are the risk factors. Ironically, if you have a look at the funnel plot on the right, you can actually see that being female doubles your risk of getting zoster, and the family history is also relevant. But in terms of the numbers, the biggest group is age. As you increase in age, it goes up. And so pretty well every decade, the incidence rises between 50 and 100% after the age of 50. That's when it really starts to take off. You can see the various immunosuppression categories. And so some of those got listed last November in terms of HIV that's untreated, people with stem cell transplants, solid organ transplants, and people with blood cancers. But there's a whole risk of others. And just be aware, people with asthma and people with diabetes also have a risk. So they're about 20% more likely to get zoster. Most people get it probably once, but your chance of getting it again is between about 5 and 10%, and that odd goes up if you are immunocompromised. You can get it frequently. So we look at the pain, and I've shown this one before, and I've got to be careful being a male because I've never had a baby, but you can see the acute pain. The author of this paper done a number of years ago was male, but zoster was rated higher than labour pain. Now, the ladies in the audience may disagree with that, but it gives you quite a severe pain, and all of you would have seen cases of zoster and be mindful of that. PHN, or post-hepatic neuralgia, similarly is actually quite a severe pain, and you can see it ranks above a lot of the arthritides and even chronic cancer pain. So as far as you can sort of try and get a pain category severity and understanding, this is a crude attempt for that, but I think most people would accept both conditions are problematic. Post-hepatic neuralgia is one of the two commonest conditions consulting at chronic pain clinics, and the other one is diabetic neuropathy. So what are the complications? From a cutaneous point of view, two things can happen. You can actually get scarring, and in certain areas, so if you get it in the first division of the fifth nerve, then the people, when they go to comb their hair, that actually is very, very sensitive. The other thing that can happen is that the little blisters can actually get infected, commonly a staph infection, and so that's the reason why we cover them. And we cover them also to prevent someone from actually getting varicella. So you cannot catch zoster from someone who's got zoster, but a person who's either got no immunity or is a very young child who hasn't been vaccinated, they could get varicella from the crusting lesions of a person that's got zoster. The neurologic complications are the main ones, and PHN sits at the top of the rank. I'll talk a bit more about stroke, but zoster, herpes is a neurotropic virus, and so it has a predilection for the nervous system. And so other rare complications are things like a transpinal myelitis, a cranial neuropathy, or even aseptic meningitis can occur from a bout of zoster. The ophthalmic one is also a problem, and that is an ocular emergency. I'll go into that more detail. But effectively, if it involves the second division of the fifth nerve, then literally all parts of the eye can be affected, and about 1 in 10 of those people can actually have permanent visual loss from that process. People who are immunocompromised can have a much worse outcome with disseminated zoster, and they will often need to be admitted to hospital and have a whole range of therapies. So they need to see the ophthalmologist. Importantly, as I'll mention again later, they actually need to be followed up because it's an evolving disease when it's ophthalmic. Now, this is a busy slide and it's new information. Let me just try and take you through. The critical points are in the boxes. So these are 3 large cohort studies. The NHS and the NHS2 are the nurses' health study. They've been done in women and they're in large groups of people. So you can see roughly 50,000 plus in both cohorts. The HPFS is the health professionals follow-up study. That was in men. And what the study is looking at is it's actually looking at cognitive decline in these populations in a cohort study after a period of having Zoster. And they asked them a number of questions which are in blue there. I won't go through them all. You can read them on the slide, but largely people are having executing or understanding or memorizing things. If you had Zoster, then you would actually have a decline of 3 points where each of those questions got a point. What's really interesting in this study, which was published in the Alzheimer's Research Journal 2024, was the effect on cognitive decline in females was only statistically significant after about 13 years. And so you can have a look here, in the earlier periods, there was really a slight change, but the confidence interval included 1. So there was really no difference from the start point. In the males, in the health study, the men, and maybe you can say they just get more stressed or whatever, but they actually had manifest subjective cognitive decline earlier than the females. Now, this has got to be replicated and is a cohort study, but it's interesting. But I'm going to present some other data later on dementia, which is really supporting that Zoster can cause a form of dementia, and that would be consistent with cognitive decline, and that reassuringly both the Zoster, the live attenuated Zoster vaccine, Zostavax, and the recombinant Zoster vaccine, Shingrix, both reduce that risk. So I'll talk about that a bit shortly. So there has been a systematic review looking at this. And again, they were cohort studies. And so those who didn't get antivirals had a higher risk. And corollary of that in another subgroup of those is that people who had who had antivirals as a result of their Zoster, actually, when they were followed up, had a lower incidence of dementia. Now, I'll tease that apart a bit later. So the risk factors for PHN aren't quite the same as for Zoster. Age is certainly one, but what happens is it's the severity of the ganglionitis, so that when you get a bout of Zoster, the Zoster virus replicates in the dorsal root ganglion, which is that little junction box adjacent to the spine. And it tends to harbor in the ones where you had the spots when you were younger. So a lot of people, it's kind of in the cervical or thoracic area. And it's largely related to the severity of that inflammatory process, which is manifest clinically by pain, the duration of it, the severity of it, and the sensory impairment. So people often get a dysautonomia or a change in the sensation where touch actually is perceived to be pain. All of those are predictors of the greater likelihood of PHN. Reassuringly, gender is not more likely. So while women were more likely to get shingles, if they do get shingles, they're no more likely than the chaps to get PHN. Immunocompromised or the dermatome affected also have no impact. And the other thing that's often been considered is shingles or Zoster a marker of cancer, or is cancer associated with high PHN, or neither depression nor cancer there's any evidence of association. This is American data. It's a bit old there, but it's really showing that incremental increase. And I showed you that in the kind of the line bar graph with the various countries, but you can see there's quite an incremental step start at the age of 50 where the rate of that goes up. And again, quite significantly, you can see that PHN jumps up each decade, becoming more problematic. Now, this was an interesting review. If you have a look at the graph, you can see these are people who've got pain and the duration of that since the onset. And so you can see that it's like a hockey stick. In the first part of the graph, in the first 3 months, it rapidly declines. And so a lot of people have pain for a while, typically lasts a month, but up to about 20 to 25%, it could still be there at 3 months. And that's when the definition of PHN kicks in. But what you can see from there is you can see that the pain very slowly declines. And so if we take out to 4 years, 48 months, the incidence is only down to about 15%. And so what you can say to a patient with PHN, well, half of you may still have pain in several years' time. And given that it's very difficult to treat, things like gabapentin is often required, or pregabalin, or some of the opioids. All of those are only marginally effective in terms of actually making a difference. So what we want to do is prevent it, and the vaccination is the trick for that. So that effect in terms of on what's happening, particularly PHN affects multiple domains of a person's life. It clearly has physical impact. So people lose sleep, they're more fatigued, they lose weight, they're less active. That has flow-on consequences. There are all sorts of emotional things associated with that. Anxiety and depression are not uncommon. It has both social things. People tend to withdraw. A lot of the geriatricians talk about someone who's had a bad bout of PHN was the triggering point for them going into residential care because they could no longer cope with the pain and their quality of ADLs. And so it is a significant condition, and we really want to try and prevent it. This is a quick summary slide of ophthalmic zoster. So the incidence varies depending on the population you're looking at, because some actually have greater surveillance and more ophthalmologists to be able to sort that out. But typically 8 to 12% will get it. And quite often it's recurrent. So ophthalmic zoster seems to be more recurrent than general zoster. Critically, you can see here that visual loss is not insignificant, 10%. Most of that is corneal scarring, but some of it due to retinal necrosis or deeper structural issues in the eye that are actually causing a problem. Let's have a look at the next one. So the impact on stroke, if we tease that out, it's clearly that there's an impact that increases in the first 3 months of that, and that declines back to about a normal level after about 12 months. And it's most apparent in the first 4 weeks. And they think it's the inflammatory response to shingles that's been accounting for that. If you look, you can see from the graphs below, there's no difference in the gender. It's interesting, though, that there is a bit of a spike in the 40-year-olds, which is, you'd be expected to be a much older populations, but largely the confidence intervals overlap, and so that may be an artifact. Again, if we actually have a look at that in terms of the time frame, going back to our 3 cohort studies, the 2 nurses' health studies and the health professional studies, you can see there that the risk of longest term stroke across all of those groups, the odds go up significantly from year 5 up to about year 13. So not only are you having subjective cognitive decline, you're actually seeing an incidence of stroke in this population. There doesn't seem to be any clear difference between male and female in those groups. So is there any benefit in actually getting the vaccine? The take-home point is the final dot point. Unfortunately, the graph is done a double negative. If you look at the y-axis there, so you've got the blue people, it looks like the non-vaccinated are having a lower rate of strokes, but you can see that the axis on the y says the proportion not reporting stroke. It would have been much clearer if they'd done it the other way around. So there is a difference. So largely the people who are less likely to have stroke are the people that are blue, and the people that have been the people that have been vaccinating have a lower incidence of stroke. Now that's more apparent in the live attenuate, in the recombinant vaccine. So there's about a 43% reduction, whereas in the live attenuated vaccine, when they looked at that cohort, that was about a 23% reduction. So I think the 2 additional things that we know from this is that it does seem that having zoster can lead to some cognitive decline. There does seem to be emerging evidence of the risk of dementia, and the risk of stroke is there, and they're both things that older people don't want to get. So in terms of do antivirals reduce the risk of stroke, the short answer is no in the review, but the recombinant vaccine certainly does. In the systematic review of that, there was about a 22% reduction in people who had a recombinant vaccine in terms of the lowering of incidence of strokes compared to those that didn't have it. So the recombinant vaccine is 2 parts. There's a glycoprotein, which is the epitope which has been targeted. So the epitope is the key part of the invading virus or bacteria where the immune system seeks out and then makes an antibody or a cell-mediated response to that. And what's new about this vaccine compared to a lot of other vaccines with older people is that they've been very successful in getting a very immunogenic glycoprotein epitope, and they've combined it with a novel adjuvant in the sort of population, and that adjuvant's now also been used in the RSV vaccine. But the combination of these 2 have led to a very effective vaccine, and I'll show you some data on that in a minute. But this is just a cartoon showing what actually happens. And so you get two benefits. You actually get a higher level of immune response, and for the protection, it's largely the CD4 count. The actual antibody levels is less relevant, but you get a higher CD4 count, so you get a better cell-related immunity, and you get a slower tapering of that immunity. And so I'll show you that in some clinical data shortly to show that the benefit actually remains. So there were two pivotal studies. One was done in people over the age of 50, so that's the Zoe 50 study. The other group was done in a population over the age of 70. The prime endpoints was to look at the protection against zoster, and in the older cohort where the PHN incidence was higher, to look at the level of protection against PHN. It was a double-blind, placebo-controlled trial. 17,000 people were enrolled. And so here are the key results. And what this is just remarkable is that you've got a vaccine in an older population where you have greater than 90% vaccine efficacy against zoster in people over the age of 50. And the other take home from this, if you look across the age groups, the protection, the vaccine effectiveness remains above 90% right up to the age of 80. And so that was less apparent in the live attenuated vaccine. And I'll show you some data shortly that continues over a period of time. So that's very reassuring that you're actually getting a high level of protection. The other endpoints were against PHN. And so there was a slight difference in those over 50 compared to those over 70, but you can see the confidence intervals overlap, and that's hovering around 90%. The other complications, like those other rare neurological events that I talked about earlier, again, about a 90% plus level of protection. So on all three endpoints, good effect. So this data, I don't think I presented this last year, but largely they've followed up the cohort, and now they've actually tracked them out to year 10. And so there's a slight decrease in the level of protection, but still you're getting around 74% protection against zoster 10 years out from the time they had a vaccine. So that's giving you a very long window of protection against a very significant disease. So that's very reassuring to see. If we look at the corollary of that, if we look at the CD4 count, which is the cell immunity, and you look at the markers of that, largely they are remaining very similar to the initial vaccination process. So it's showing that the biological plausibility is that we think the largely the protection is your CD4 cell counts. They're holding up and they correlate with clinical protection. We can't readily measure them clinically at all, but no, you can be rest assured that people are going to get 10 years of benefit out of this vaccine. So the side effects, the downside of having a better adjuvant is that largely you're going to have more people with a local effect. And you can see this. So that the purple group are the younger population, and the kind of maroon group are the older generation. And it's not uncommon in vaccines that the older you get, either they complain less or the effects are not as experienced as bad, as severely as the younger population. But you can see that pretty well 3 out of 4 people in this group are going to have some sort of local reaction. So they need to be warned about that. You can also see that the main one is pain, but about a third are going to get redness, and about 25% are going to get some swelling. And if you look at the severe reactions, again, they're generally under 10%, and they're pretty short lasting. They're lasting 2 or 3 days. I had a colleague who had a vaccine in Melbourne recently, and he got quite a severe reaction. He had his 12 months after his first one. There was a reason for the delay. But doing a bit of homework, it turned out he'd actually had it at a pharmacy, and unfortunately, he'd actually had the injection subcutaneously. And that's been particularly noted that if you give it subcutaneously, you're going to have quite a bad reaction. So you really need to make sure that this vaccination or this vaccine goes intramuscularly. Looking at systemic reactions and grade 3, if you have a look here again, it's pretty common. So you can say 50% of the over 70s and 2/3 of those over 50 are going to have some sort of reaction. The commonest are fatigue and headache and myalgia. In terms of the more severe ones, they are, again, under 10% of the total and follow a sort of similar pattern. Reassuringly, and this is a bit of a complicated slide, if a person has a bad reaction with the first dose of their COVID, of their vaccine, they're only about a third as likely to have a similar severity reaction the second time round. So they should not be dissuaded from having that. And it is very important to get that second dose, as shown here by this graph. You can see that getting the first dose, you get some sort of response, but really the level of T cells only takes off after the second dose. Now, the Commonwealth have actually changed the time interval. So ideally, it's 2 to 6 months for adults who are immunocompetent. They have lowered that to 1 to 2 months for someone who's actually immunocompromised, so that they can actually get a rapid response, partly based on the fact that they really are not giving good protection until they've had their second dose. So it's really important that people get the 2 doses. So the NIP changes in September. They have expanded that to the moderate to high risk groups, and I'll give you the web link soon that actually lists those various conditions and medications. And they've now classified the group of immunocompromised people, and they can now audit through the NIP channels. And I know a lot of people have had trouble in getting issues. I think the Commonwealth is surprised by the number of people that are wanting the vaccine, and by putting it on the NIP, that really turbocharged the take up. And I'll show you the coverage. I think we can be pleased about that, but I think there's quite a few clinics that are a bit frustrated because it was very hard to get adequate doses when they were running clinics and offering vaccine to people. So looking at the compromise, this is just looking at their risk of getting zoster. So the base case I see is immunocompetent or immunocompromised free. So that's kind of the people that don't have any of these conditions. Stem cell transplants really lead the pack. Hematological malignancy, HIV infection, solid organ malignancy, they were all on the list for the NIP when it was actually listed for Shingrix. But a number of these others now have been included, and they're really included around some of the conditions, but also the medications that they're actually going to be taking. So here's the slide with the 2 links. And I think Anastasia is going to copy that in the handout. The first one is the updated chapter link in the immunisation handbook, but this one below is largely which groups are going to be particularly at risk. So what I've taken is Tony Cunningham's excellent summary of kind of looking at the level of immunocompromise and what we knew about 12 months ago in terms of who should get the zoster vaccine. And you can see that that recommendation has now been updated for that. And so we've got, so all of these conditions, and what I've done is out of this web page, I've taken it for the ones at moderate risk, and that largely TNF inhibitors, JAK inhibitors, and T cell inhibitors like cyclosporin. If anybody has had one of those and they're on it currently or in the last 6 months, they are now eligible for the zoster, the recombinant vaccine right now on the NIP. Interestingly, on some of the other conditions, azathioprine and methotrexate have stayed at those doses, so more than 3 milligrams a kilogram per day for azathioprine and greater than 20 milligrams a week for methotrexate. But they've made no comment on hydroxychloroquine, sulfasalazine, or low-dose steroids, which is interesting. So I'm assuming there's no comment is they don't see that that is a particularly high risk that that person will be on the NIP. So if we actually look at those specific populations, the ones that were recommended early, the graphs to look at, or the tables to look at, are the ones in the green boxes. And so if you look at the overall there, in people with HIV, then they have a 90% vaccine effectiveness. Oh, sorry, they have a CD4 count, which is 94% overall level of protection. In autologous ones, it's very similar. It drops a bit with renal transplants and hematological malignancy, and it's a bit lower with solid tumours with chemotherapy. And you can see in the older population, that does drop a little bit compared to the younger population. But and here's the slide on the clinical effectiveness. So we have that with stem cell transplants, the HSCT, and you can see overall protection against zoster is about 69%. A protection against PHN is about 90%. We don't actually have data for the hematological malignancies other than the overall, which is about 87% protection. There are other studies in those other immunocompromised groups looking at clinical endpoints, but the 3 questions with immunocompromised people that we want to have answered is this vaccine safe to have? And we can say yes. Yes, you'll have local effects, but you will not get you will not get zoster or varicella from the disease because it's not a live attenuated vaccine. Will you get protection? And so will you get a decent immune response? Now, that might depend a little bit on the timing of it. A lot of the initial studies that are reported here haven't really separated out the time, but that is the thing which I think is clarified in some of the in the tables that the Commonwealth have put out, and it would make sense. The timing would be, sort of either in terms of a sufficient time prior or after the event, and that will vary with the conditions to doing that. And then the third thing you want to know is, will this work? And so the if they get an immunogenic response, it's very likely it'll work, but it's nice to have that reassurance of clinical data, and we're still waiting for some of those studies. This is a busy slide, but largely it can be summed up that if all of these conditions, the local effects are even higher than in the population. So what I put the red bar is someone who's immunocompetent, what their level of adverse effects are. And you can see that in some of these conditions, particularly HIV, that they're actually quite high in terms of local effects, but they're lasting relatively short period of time. The hatch bars are the severe reactions, and again, they're generally under 10% of that population. Looking at solicited systemic effects, again, common in this group and higher than the general population, which is marked with the red bar here. So this last table is those over 50, making it comparable to the people that have largely made up those getting the zoster vaccine. And again, HIV is quite notable, that severe populations there, systemic reactions. But the severe grade 3 ones are only about 10% and generally very short lasting. So this question, we raised the risk. We said, I showed you some data that there was an impact on cognitive decline with getting zoster. And so the corollary, what we'd be interested in is, if you got a zoster vaccine, will that reduce the risk of dementia? Now, I presented a couple of cohort studies in the previous talk last year, and at that stage we really didn't have much on the recombinant vaccine Shingrix. And so it's been a very interesting study. It's been published in the last month in Nature Medicine, and they did a natural experiment because largely Zostavax stopped in 2017 and was taken over, complete changeover to the recombinant vaccine. And so what they did is they looked at people who developed dementia, and they looked in a large database about people that had actually had the recombinant vaccine, which was after October 2017, and those that had the live attenuated vaccine, and they plotted their risk of dementia. And they put it in a slightly funny way. They've actually reported it. So this is comparing one group with a zoster vaccine against the other, and they're comparing against the live attenuated. And you can see that the effect was more pronounced in terms of the reduction in dementia. And the way they've reported, rather than the actual number of people at a point prevalence, they've looked at it as a bit of a continuum. And there was what they've reported is that if you had a recombinant vaccine, you'd have approximately 164 days or half a year live without the diagnosis of dementia, compared to someone who had the live attenuated vaccine. What they haven't done is actually look at those that didn't have any vaccine, when that would be a very interesting comparison. But it's actually giving us some evidence in a kind of a way when you can't necessarily do a randomized controlled trial on these people, that supports the suggestion that people who get a zoster vaccine, it does have some impact on lowering the risk of their dementia. So we look at coverage. We've actually got the live attenuated vaccine, and you can see pretty well when the pandemic started, people stopped getting the zoster vaccine. They were too busy getting their COVID vaccine. And the updates here, you can see largely the live attenuated vaccine plateaued at about 41% in the 71-year-olds. If I look at the most recent data, this is taken from the NCIS website and is up to, from the period of 1st of November last year until July, how many people have had the recombinant vaccine Shingrix. And you can see across, if you look at the overall, the last three bars, the dark blue bar is the adults over 65. About 27% of the population have had a recombinant vaccine. So if you add the two together, we can say that 2 out of 3 people in Australia over the age of 65 have probably had one of the two zoster vaccines that have been available in the last 8 years. So that's about comparable with what the flu vaccine is doing. But that means that 1 in 3 people have not had it. So all of this, it's for prevention of zoster and for post-hepatic neuralgia. Don't give it if someone's had a reaction and if they've had an allergic reaction to any of the excipients. So the first dose will be the tester for that. And it's, as I said, make sure it's an intramuscular injection, and the interval is 2 to 4 months for immunocompetent people, but that can be 1 to 2 months for people who've actually got a degree of immunocompromise. Just before I finish here, I just wanted to show you from, I think this is still relevant. This study was done 15 years ago, but I think when I've looked at the evidence in terms of the predictors of vaccination, it still stands true. So for the people that haven't got it, if you look at the bottom half of, if you look at the top half of the table, who are those that are not getting it? So if they don't believe they're going to get it, they're not going to, they're not going to get the vaccine. They don't believe it's not needed because they rarely get sick. They have good immunity. They think the natural immunity is better. They're concerned about whether it works or the adverse effects are problematic, or whether an allergic reaction, or it can cause shingles, or you haven't discussed it. So I can answer a couple of these. The risk is 1 in 2. You don't have to go anywhere. You can get it. They've got it. And 95% of the population have got serology evidence that they've actually had varicella. So that you're all at risk. You cannot avoid it. Not needed, you'd really get sick is not a good marker of that. As I said, it's age. Your kind of health status is not a predictor of getting zoster, but your age is. And that they're in good immunity, it's hard to know. We can't easily measure that, but the likelihood is they're not. And natural immunity, why do you want to get the disease with all its consequences of like PHN when a vaccine can prevent that and also prevent the complications? And I've given you good data on both the effectiveness of the recombinant vaccine and the safety of the vaccine. And the allergic reactions are incredibly rare. It cannot cause zoster because it's not a live attenuated vaccine. And there is a group of people, when you haven't talked about it, they make an assumption that you've decided they don't need it. And so it's always worth making a discussion about that. Difficulty in the CGP, fortunately, it's not as problematic as it in Canada, where 1 in 5 people can't get to see a GP. But most people here can, and most GPs have got really well-organised clinics where the practice nurses run and make sure that all happens. And so the corollary of that, of what makes a difference, is a good recommendation from you or the practice nurse, getting other vaccines, regular attender, higher level of education, older age. I might stop there, but I'll leave it on the screen to linger just while we sort of get to the end of it. But when we did this study, we actually asked them about whether, if a GP recommended, what impact that would have. And if you look at pretty much all of the negative misperceptions or concerns, pretty well all of them, you would get a very big rise in vaccination if you actually made a recommendation, even if the concern remained. And I'll highlight on the next one just to fact 2 points. So I could get shingles from the vaccine. You can't do that. But when we ask people, nearly a half of that population, this is a survey in terms of 1,300 people matched to the Australian population, they were either unsure or agreed that could happen. Now, if they had no recommendation, less than half would get the zoster vaccine. With a GP recommendation, that would go up to 74%. Have a look at the one on the bottom. I do not need a vaccine, because I really get sick. That again was happening. 40% of the population stated that. Now, if they believed that and there was no recommendation from the GP, only 30% would get the zoster vaccine. If you recommend it, despite they believing that, because they don't think that it's needed, 68% would be prepared to get the vaccine. So I think that's a really important point, is that the comments you make about a recommendation often counter negative attitudes, and that can be done in a relatively timely fashion. So in summary, lifetime risk 1 in 3, complications are significant. Increasingly, we're sort of getting evidence of dementia and stroke that may happen from zoster, and some degree of protection, certainly from the vaccine. And we've now replaced the live attenuated vaccine with a recombinant vaccine for people over 65. We've now got good evidence that we've got at least 10 years of immunity. We've updated the information for immunocompetent groups, and we know it's immunogenetic in a lot of these groups. The coverage has plateaued. We've got 2/3. That's a great job. I mean, that's where we stand with the flu vaccine currently, but we could do better. And I should have added, apologies to the practice nurse, I should have actually added in that a practice nurse recommendation has a similar effect to the GPs. I think I might stop there. I have some sort of FAQ questions, but it's far better to actually answer the I'll stop sharing the screen, Andrew, to make it a bit easier.
Great.
And I'm happy to take any questions. And just to be reassured, if we don't get to your question, they will be addressed at a later point.
Thanks, John. Wonderful overview, very detailed, and thanks for sharing the new data on immunocompromised patients over 18, not just the categories, but those that are on the medications as well. So it is a rather long list, as you say, but we'll provide that over the next week or so. So a number of questions. First question. Shingrix was available in November 2023. There were some initial teething problems with stock availability, but that's now been solved from around about sort of April and May this year. Have we seen the benefit of Shingrix in the population of 65 years and older at the moment?
I haven't seen that data. You'd actually need to have linked data. I mean, we did this early on when the live attenuated vaccine was there, but there's enough evidence from overseas that they've seen a decline in the incidence of zoster, so that there is real world effectiveness. And like big groups like Casa Permanente, the health capitation health groups where they've got millions of patients registered, they've followed up and they've actually seen a decline. So it'd be nice to have Australian data, but it's still fairly early on, and we don't have that data linkage that we can get that very easily.
So how long do we have to wait to see a significant reduction in the over 65s?
Well, we should, if we could link the data, we should be able to see it immediately. But that's one of the problems. We don't. People are reluctant about putting things on the My Health record, and it's very hard to link information like vaccine status with whether a person got zoster, even though zoster is a notifiable disease. There's no easy way to do that. But I mean, you could do a research study, which would require some funds to do that, but we should push the Commonwealth to say you should be reporting that and actually assessing that. But it's a broader issue, is that vaccines with older people, unfortunately, don't get as much airtime as the pediatric vaccines. And so, some of the coverage data I showed you, it's the reason why it's a couple of years out of date.
Okay, a question here from Liz. If there was an increase, if there is an increase after the age of 50 years, and I can see that on the NNDSS data, why then is the vaccination funded only from 65 years? And I'll add to that, I did have a look at the data, and it seems that from the 65 years and over for this year, the number of confirmed Shingrix cases has reduced, and now the peak is between 60 and 65. It's only 1 year and it's only a snapshot. But if we do well in the over 65s, what do you think the likelihood that it will come down fully funded to another?
It's a challenge. Look, the clinical data is there. The incidence is a bit lower, but the clinical data is it is effective. The real problem is the cost effectiveness. And what I actually learned in the last 6 months is that the criteria that the PBAC apply to cost effectiveness for vaccines is a much lower level. In other words, it's much harder for the vaccine manufacturers to demonstrate cost effectiveness of vaccines for a number of reasons than a medication. And one of the things is because they apply a discount factor, so that if you want to give protection for 10 years, it's like if you have $100, do you want it now or do you want it in 10 years' time? And the answer is you want it now, because inflation will mean it'll only be worth about $50. So the nutshell is it's quite difficult to present that data to get a Guernsey, but it is on the list. So in other words, the TGA, you can get a recombinant vaccine over the age of 50. You just have to pay for it, and you need to ring around. So it's $300 to $350 a dose and you need 2.
That's right. Yes, I was 280. I decided to cough up and 2 doses, so it cost me $560 because I'm not over 65. Yes. So the other question here is, first, I had a patient, they had a bad reaction, a severe adverse reaction on the first dose. They've refused a second dose. I guess it's really the question of what conversation do you have with the patient to reassure.
So I did show a slide, and Tony Cunningham has reinforced this, is that the chance of having an equally severe reaction is substantially reduced. So 2 out of 3 people who had a bad reaction the first time will have a much less reaction the second time round. It's hard to predict which ones will do that. The other thing is, I gave you the anecdote there, is if you want to be sure, I mean, most nurses are very good at giving vaccines, and with no disrespect to the pharmacists, that they're new to the game in a sense there. My colleague who had it, and he sent me a photo of his reaction, and it's pretty clear he had a subcutaneous injection, and that can be a problem. So that if it's an inexperienced vaxxer, that could be the issue. So that'd be clear. But if they had it in the clinic, I'm sure they would have had it intramuscularly. All you can do is talk to them. The other slide I showed is that their level of protection is much lower after one dose. It's a two vaccine deal to get the best level of protection. And so you're not going to have as much protection. And in some way, you've spent your money, but you're only going to get a modicum of the level of improvement for that. So, but do it, I think, to acknowledge the people have had a reaction, and that's unfortunate, and just say, just try and explore what their ideas about what getting Zoster would mean to them, and allow them to make the decision. And normally, if you kind of listen to what they have to say and present that information, a lot of people might decide to take it. And that's all you can do, I think.
Okay, question here from Catherine. Hello, Catherine, from SA. So they had first dose of Shingrix was administered. Then they got, from what I can read, they got the zoster virus. How long do you have to wait before giving the second?
Look, that varies a bit, but they could certainly have that sort of, like they're saying 3 months onwards. The level of protection, we can't easily measure it. I would say sort of 3 to 6 months after that, that would be reasonable.
Okay. It was an initial question here. So with the administration of Shingrix to immunosuppressed patients between 50 and 65, they've received their second doses. This is actually in the immunization handbook. They've received their 2 doses. Do they need a booster in the following years?
No. They don't. There's no countries that are actually looking at boosters. And I showed you the the cell immunity, you're still having 10-year data. Now they'll follow up the immunocompromised people. They might be in a sort of situation, but nobody's talking about giving a booster at this stage.
Yeah. Can exposure to people with active zoster, which contains the virus in a blister, boost immunity like exposure to chickenpox? And
I just didn't catch all of that. Which one was that one, Andrew?
You see that there? It's at 610.
Okay, hang on. I'm not. 610. I've got nothing on 610. Oh, hang on, my time.
Oh, you're on different time. So 5:40.
Sorry, I'm looking at the wrong. Okay.
Can exposure to people with active zoster, which contains the virus in the blister, boost immunity like exposure to chickenpox?
Yeah, look, technically it can, and we believe that helps, but it's unpredictable, really, and you just don't know the duration, and you can't quantify it, so you can't easily measure it. I would say irrespective of that, and we know that people that have had recent zoster can get the vaccine. I would say no, look, don't count on that. Get the vaccine. There's too many elements that are uncertain in that.
Okay. One here from Nancy Lee. Her patient has received Zostavax already. How long do you have to wait until you get the new?
So this gets a bit tricky. There are 2 time steps. If someone's paid for a Zostavax, they can have theirs 12 months after. That's the recommended. If they get it on the free program, they've got to wait for 5 years. And largely, a cynic would say they're saving money, but largely you do get protection. I see another question. That people can expect pretty reasonable protection from Zostavax after 5 years. It just won't be quite as good as Shingrix. And they're saying, if you want to pay for it, you can go in and get it earlier. But if you've had a public campaign live attenuated zoster vaccine, you'll need to wait 5 years if you want to get Shingrix. And you'll need 2 doses of Shingrix too.
So there's a couple of questions from the same person here, so I've got to read it all out. So the first question is, first aware that the risk of shingles may be 15% higher after COVID. The first time aware of this. What is the connection between COVID and shingles?
Okay, let's do one at a time. Rather, I'll get connected. Let's do one of the. Yes, there is. I have a slide in the FAQs, but largely there is about a 15% risk, and it's actually 21% increased if they're hospitalized with COVID. And we know that a number of viral infections will trigger an exacerbation of herpes. And we actually know also that someone who gets a COVID vaccine, they have a slightly higher risk of reactivation, but it's not quite as high as with the COVID. So yes, there is a risk, but it's not a specific effect from COVID. Quite a few viral infections will actually trigger an exacerbation of shingles.
So shingles is still quite prominent to catch at 50 years old. This is one of the second question here. Is it worth, recommending to get the shingles vaccine? It won't be funded, of course, if you're in that sort of 50 to 60 age group, or should you wait until you're 65?
I think that's an individual choice. It is an expensive vaccine. I've said I don't think it's going to come down onto the NIP in a hurry because of the price of the vaccine. And we're having the same issues with the RSV vaccine at the moment. If people are really worried about it, your risk is not inconsequential at that age. I mean, your risk is going up. So I said it's about 40% for someone who's 60. It's going to be somewhere between 30 and 40%, but you don't know where that's going to be in that next decade or afterwards. We do know that you'll get at least 10 years protection. I've had discussions with Tony Cunningham, and he's looked at the cell-mediated response, and that curve is remaining high in people out beyond that. So that, how long a Shingrix dose will last, we don't know. And, if you want to reduce your risk, that's a reasonable thing to do. You may get some money back. I got very little back from my from my provider when I got my Zostavax vaccine, and so if you've got private extras, but that will be modest in terms of what you'll get. So it's an individual decision. It's worth teasing out the options for people, and it would be a reasonable thing to do. There's a question above that with children, which is probably worth asking. If they've had it, the thing is, if a child has the sort of primary and secondary failure rate of the varicella vaccine, in other words, not getting a good response immediately or the vaccine decaying, after about 20 years is between about 10 and 20%. So in other words, the varicella vaccine is good, but it may not prevent someone from either getting varicella or subsequently getting zoster. And so if people get a rash that looks like varicella, then you really got to say that they could well have varicella, but it becomes much more common as they get older. But what we're hoping is most of the children will have a level of protection, because by never getting varicella, they don't get the latency of the virus in your dorsal root ganglion.
The question further down. For the immunocompromised patient in clinic, in the hospital, being treated by a hematologist, oncologist, and support by the nurses, whose responsibility is it to recommend and give Shingrix or shingles vaccination?
No, I always worry about people falling through the cracks.
Or does it flow into the GP zone?
Yeah, look, I think, and we're going to be running a masterclass for specialists in a couple of weeks' time, because they don't seem to have as much engagement often in the vaccination. I'm always worried about people falling through the cracks, and I would say that everybody has a responsibility if there is an opportunity. But the GP, like the conductor, you really need to know, because you're seeing that person probably much more frequently than the practice nurse is seeing them more frequently than the specialist. So don't assume they're going to do it. We would hope our specialist colleagues are getting more engaged in it. But I mean, if you can do it, a lot of the practices now run clinics. I've two of the practices in Adelaide we're getting for our masterclass. They've got Shingrix level coverage of up around 75% by running clinics, and they've got very large older populations. So the GPs and particularly the practice nurses now do that really well. I would say, you don't have to assume responsibility, but if you're thinking the other person's doing it, check it out first. Don't assume it's happening, because people do fall through the gaps.
Okay, maybe just a couple more questions, because it's 7 o'clock and we do want to wrap up on time, just to respect everyone's time. You see there a patient developed shingles. I've seen this question before. The patient developed shingles the day after receiving this first.
Well, how
do you deal with that?
Well, that people may be disappointed about that, but we know there's absolutely no evidence that the recombinant vaccine causes it. It's not a live virus, so that there's a window. It's sort of like the people who late in the flu season rush in to get a flu shot, and they get flu, and they think it's caused by the injection. there's an incubation period, and no, not incubation. There's a period before your immunity rises. And I showed that graph about the thing of that. So for flu, it's around 2 weeks, but we can see you're going to have full level of protection sometime after the second shot with the recombinant vaccine. So it's a longer period of time. Now, you can't predict it. With flu, if you're around people with respiratory symptoms, you've got a risk. You don't know in terms of when the Shingrix or the zoster is actually going to happen in a way. So I think that's unfortunate, but you can categorically say it did not come, particularly if they had a recombinant vaccine. There was a very, very small proportion after the live attenuated one, but it's pretty uncommon.
Last question then. There are many more, and we will provide the answers in a week's time when we send out the Q&A transcript. So we will get to them all. It's just we're at time here. So patients had their, this I think is not uncommon, they're outside the 6-month second dose, maybe 8, 9, 10, 14 months later. Better to have it rather than not.
The immunogenicity data they've got out to about 12 months, and it's fine up until then. So, but I would not be pushing it. And most of the practices are using hot docs or one of those other things there to set up the reminder there. So, and follow people up. But I would say, look, out to 12 months is fine. But as I've just said, just like that other one who got it afterwards, the best protection comes after you've had the second dose. And so I would ideally say book them in 2 months afterwards, so you give yourself a window to chase them up for that. So you can make sure you've got lots of time to get them in the recommended, which is 2 to 6 months for immunocompetent and 1 to 2 months for immunocompromised.
All right. Okay, we're going to call it there. So thanks very much, Professor Litt, for taking us through your slides. They were fantastic, very well, very detailed. As I said, those questions that we didn't get to, we will provide them in about a week's time. Thanks everyone for participating and joining us. It's been a long year. This is the last of our IC disease-specific webinars. So we ran 8 this year, so this is the last one for the year. So looking forward to the break. Just to let everyone know that our next main event is our annual scientific meeting on the 9th and 10th of February. The details will also be provided to you. It is a hybrid meeting if you want to join. It will be in Melbourne, but there's a hybrid option as well, so you can join online. So with that, John, you might want to say a few words, but I'm just going to say have a good break. Merry Christmas. It is a month and a half out, but time will go quick, and I look forward to seeing you next year.
Andrew, a 1-minute comment. Please look at the long COVID risk calculator. We're going to have a few podcasts, one with Professor Stephen Foe, who runs the St. Vincent's Clinic, and Brendan Crabb. Long and the short, if you get COVID now, you have a 5% chance of getting long COVID. The average duration of long COVID median duration is 4 months. One of the people who's going to talk on the podcast is a lawyer, and she had 3 years taken out of her life, which is 11 months she couldn't get out of bed. So the current strain of circulating COVID, 5% chance of getting long COVID. You don't want to take a long time slot out of your life. Have a look at the long COVID risk calculator. It actually highlights what you can do to lower the risk. And essentially, the less bouts of COVID you have, and having a recent booster gives you the best protection.
We'll send out that information and the link to the podcast as well, so they'll get all of that.
The podcast will be coming. There'll be
the ones that are coming, but there's still some already available, aren't there?
Yeah, I think they're just in the process. They've had a lot to produce, so they're going to have them out pretty soon.
Okay, good. All right, well, that's it. So thank you for joining, and good evening and good night.